Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hi there, my name is Arlene Maxim, and I am the Senior Vice President for Clinical Services at Axxess. And today we're going to talk about the 2022 Home Health Final Rule Changes. Be assured that Axxess has everything ready to go for 2022. So as an Axxess user, you can be confident that you're going to be able to continue working as you always have. However, there are some things in the final rule that you need to really pay attention to, because some of them are going to require you to not only do education, but also change some of your policies or revise some of your policies within your organization. So you're going to want to listen closely, and I'm going to give you some tips on how to make sure that you satisfy each one of these rules in the final rule that came out at the beginning of November. We usually get those on Halloween, actually, but this came out the beginning of November. So we've had a little time to take a look at it and get ready. There are some things that are going to be coming up in the next 2 weeks, so we don't have a lot of time to prepare, but hopefully this webinar is going to help you get ready in your agency and get your staff ready for the changes that are upcoming. So value-based purchasing is an interesting one. This is one that was very shocking to me. I thought sure that we were going to have value-based purchasing start in 2022. However, they decided to allow us to have a year for implementation and do some research and get our ducks in a row for our payment process that will begin in 2023. So those of you who aren't familiar with what value-based purchasing is all about, it's a program that's designed to incentivize quality of care delivery. So the agencies who will do better in organizational performance will actually be paid more money than those agencies who are getting or doing less quality of care. And those are all going to be extrapolated from your OASIS information. One of the issues that we have is that OASIS-E and value-based purchasing are going to start at the very same time. I would encourage you to begin this month, next month, in January, to train your staff on OASIS-E. It's going to impact your value-based purchasing reimbursement significantly. And the OASIS-E is a huge change for us. If you look at it, it doesn't even look like an OASIS document any longer. But the Centers for Medicare and Medicaid Services tested value-based purchasing in 9 states. They stopped the testing a little bit early. Part of it had to do with COVID-19 and the pandemic, part of the early stopping of the demonstration project. But they found that they had significant savings. They had $141 million was the annual savings to Medicare just with 9 states. So if you take that and multiply it times the rest of the states, that's a significant amount of money. So CMS is going to roll this out nationwide. The demonstration states had an 8% decrease or increase. We are going to have a 5%. So they have reduced that a little bit. But that's a significant amount of money if you calculate that. And I would recommend that you do that with your agency, because some of the agencies that had the demonstration project actually lost a lot of money. Some of the agencies actually went out of business. So you want to make sure that you have your staff trained adequately with OASIS-E, and that you understand exactly what's going to happen if your quality information is not there. We've been working on QAPI for the past couple years, so you want to make sure that your QAPI program, excuse me, is intact and is working like a well-oiled machine. QAPI is going to be very, very important for you over the next year during the implementation phase, and certainly in 2023 as we see CMS begin working with the data. So in 2020, CMS stated that the value-based purchasing program would use a baseline of 2019. They are going to eliminate any data that was collected during 2020 because that data was so skewed as a result of the pandemic. In 2021, they expanded the implementation of the value-based purchasing in the final rule. And then in 2022, this is the year that they're calling an implementation year, but it is the year that we really need to take a serious deep dive into our quality in our organizations and make sure that we have a solid QAPI program and that we are providing the very best quality to our patients. And I know you all have tried to do that, but we have to get really, really good at our OASIS documentation, making sure that we can show how we've improved. And that has been a struggle for us ever since OASIS started. So I would encourage you over this next year to really get familiar with OASIS-E. That's going to be all new, and we are not going to be able to just switch flip a switch on December 31st, 2022 and say, okay, tomorrow we're going to start OASIS-E. It's not going to be that easy. There's going to be a lot of training that needs to be done and a lot of policy changes that you will need to implement within your organization. So there are going to be some increases. The proposal allows for a 1.8% increase for 2022, and that is going to equal about $330 million. So we'll see for the base rate, we're going to see from 1900 to 2013. So that there will be a reduction on the rural add-ons. So those of you in the rural areas are going to see some changes that we've enjoyed for the past number of years. So because of the $20 million rural add-on decrease, the aggregate increase in the Medicare payment will total 1.7 or $310 million. So home health providers, again, are going to see a little bit of increase in the total home health spending that's set out in the final rule, but there are no changes made to the phase out of the rule add-on 2022 is going to be the last year for the rural add-on. So those of you in those rural settings, those low population density categories will continue to receive a 1% add-on, but the rest of you will see that decrease. And so you will have to prepare for that in getting ready for this in 2023. This is a big change for us, and this is, I think, a welcome change. This is an exciting change for home health. CMS doesn't always give us things that we should be happy about, but we're going to start using something called a notice of admission. This is going to be very similar to a notice of eligibility that hospice has been using for years. But this is going to eliminate any talk about RAPs, the request for anticipated payment. We will not hear the word RAP any longer. We're not going to have a no-pay RAP. We're not going to have a RAP. We're also not going to have any money up front as we had with the actual RAP. But this is the process itself, and the dollar amount and the way we're paid will not change from this past year. But instead of a no-pay RAP, we're going to submit something called a notice of admission. That notice of admission will begin at the, well, not begin, but it'll be only at the start of care. You will not have to do anything at the 30-day period. You're not going to have to do anything at research. You will not have to do anything at resumption of care. You will only do a one-time notice of admission. If the patient's discharged and readmission, the NOA is going to have to start again. So some of you who have policies, and I know that there are many agencies out there that still do this, when a patient goes into the hospital, they discharge them and readmit them when they come back out rather than do a resumption of care. That's probably not a good idea with this in mind, because you're going to have to do another notice of admission and process that notice of admission. So for patients who are on service on January 1st, that's going to be something you're going to have to watch very carefully, and you should be doing this over the next week or so. Those patients will have to, you're going to have to submit a one-time notice of admission at the start of their first 30-day period in 22. Now be really, really careful of that, because if you don't do that, they're going to begin discounting your payment by 1/30th of your payment from the time that you submit your notice of admission. So this establishes these common working file is going to establish an artificial admission date so that we can get all of those patients that are on prior to January 1st, 22 on the same program, and they will all then end up with a notice of admission. But make sure you're tracking that. So actually over the next couple of weeks would be a really good idea to have your staff make a list of all those patients that have been admitted in November and December, and some of those that are ongoing research, so that you can get that first notice of admission in prior to that 30 days. So here's a couple things that you're going to have to pay attention to, and these are not unlike what we've been doing for the no pay wrap. You're going to have a verbal or written order from the doctor that identifies the services, so whether you're going to have skilled nursing, home health aid, for the initial visit, and you're going to have to conduct the initial visit. The notice of admission needs to contain the primary diagnosis, and again, that can be generic, just like it was for the no pay wrap. I want to point something out here because I've had a number of agencies believe that a billable visit has to be a completed OASIS visit. That's not the case. A billable visit has to be a billable visit, just as it indicates. Now, for patients that are being started, so you're doing an admission on them, they have to have their eligibility requirements intact, but then you have to only do a billable visit. So you're going to be doing something like observation assessment, you're going to be doing some teaching, perhaps wound care or something like that. But the OASIS itself and the comprehensive assessment is not a requirement to be completed, nor do you have to have the document in hand at the agency. As you've been doing, hopefully, with a no pay wrap, the clinician would simply have to call the agency, let them know they've completed the first billable visit, and then the agency can take it from there and submit their notice of admission. As I mentioned before, untimely submissions are going to result in a daily penalty equal to 1/30th of reduction of the wage adjusted 30-day period payment amount for each day that you have a home health care start of care date until you submit that NOA. So it's very similar. These rules are very similar to the no pay wrap, but the beauty of this is that you only have to do this once. This payment reduction is going to apply to any outlier payments as well. So that could be a significant amount of money if you do have patients in an outlier situation. So they've given us some exceptions, and they're very similar, or maybe exactly like that we had for the no pay wrap. If the NOA is submitted outside the 5-day calendar window, so they've said that fires, floods, earthquakes, any kind of unusual events that have extensive damage to the agency, certainly those folks in Kentucky in that area, they would fit into that category. In the event that produces a data filing problem due to CMS or MAC system changes, if it's out of your control, and you make sure you document that and you keep dates and that type of thing, then that would be an exception. If you're newly certified and you don't have your notice of certification yet, and you're waiting for your provider number, that's going to be an exception. Then other circumstances that your MAC determines is beyond your control, but you're going to have to be very, very careful. I've always recommended that agencies, if they have unusual events such as tornadoes or earthquakes or something like that, to actually keep copies of newspaper articles indicating that actually happened. Take pictures of what went on in your agency. I've had agencies who have had significant flooding. They've had just flash flooding, and they weren't prepared for that. I've had a couple agencies that I've worked with in the past that have actually had their agencies burned down to the ground. So those types of things are going to be the exceptions, but they're going to be pretty stiff. So you're going to have to make sure that you have a really good documentation to indicate what has happened that has not allowed you to submit that notice of admission. Your case mix weights and your groupings are going to change a bit. So we expected this. There was a recalibration of PDGM case mix. Now we've been working with PDGM for a couple years now. So they've looked at that data, And there's going to be an increase in low comorbidity subgroups from 13 to 20, and an increase with high comorbidity subgroup pairings from 31 to 87. So most of these are going to be in the functional impairment areas. So again, I would highly recommend that you do a specific training program with your clinical staff on what comorbidities are significant to assist you in gaining the highest rate possible, because some of the clinicians that I found just don't understand this. And so I would make this a special training program for yourself. The LUPA thresholds are going to be the same throughout 2022. There is a little bit of a change that I'm going to go over later in this session for occupational therapy. But CMS used the 2020 PDGM data with linked OASIS data as of 2021 to recalibrate these case mix weights. So some of, if we don't like the changes, some of them are self-imposed because we either rushed through OASIS or weren't really paying attention to what we were submitting. So we have to start taking a much more aggressive role in making sure all of this data that we're submitting to OASIS is absolutely as correct as we can get it. So again, there's an increase for functional impairment points for the risk of hospitalization in OASIS. So again, that risk for hospitalization, I think agencies have not done the best job that they could as far as risk is concerned. And the way I train staff to do it, and you might want to adopt this, is to look at your patient, look at your assessment, and ask yourself, would I be surprised if this patient was hospitalized over the next few weeks? And if that answer is no, then you're going to want to make sure that you have a really good documentation of why that risk is there and what that risk is and what you're going to do to avoid that risk. There's a decrease in points for grooming, bathing, ambulation, locomotion, OASIS items, and primarily that happened because they were pretty much seeing consistent numbers throughout the data research on this, that we were pretty much checking the same boxes all the time. The point thresholds are lowered for various clinical groupings overall, and again, that's just seems to be related to the type of patients that we're getting. Now, this one I want you to pay really close attention to and write some of this information down. The 14-day supervisory visit will still stay intact. There's no change in that. We're still, as we always have, we're going to have to do every 14-day aid supervisory visit. What the final rule did was they adopt some of the pandemic changes, waivers that they made, and they're going to allow one virtual supervisory visit per patient per 60-day episode. What I want you to understand is this is not an arbitrary virtual supervisory visit. You have to have a very, very good reason, very similar to what we see with the notice of admission not being submitted. The virtual visits must be used and needed and is not as a routine part of the supervision. So with that said, you cannot schedule on your plan of care one supervisory visit every 60 days for every single patient. You're going to have a really, really good reason, and you're going to have it very well documented. So surveyors are going to be watching for this. As far as the MACs are concerned, they're probably not going to pay much attention to this. However, you could likely get a condition level citation if you routinely have virtual supervisory visits. They want you to make sure that you have everything documented as to why you would need to perform a virtual visit, and you need to be able to see that patient. It's not a telephone visit. And so you have to be very, very careful. So make sure that your staff understand this. There's only one, so you're going to have to track it as well. So if you used up your one virtual visit, you're not going to be able to do another one. And there has to be a really, really good reason. A clinician being sick and can't get to the supervisory visit is not a good reason. You as an agency are responsible to make sure that these supervisory visits are done. So the only thing that would happen would be, you know, again, the same types of things as your notice of admission exceptions, like snowstorms or something like that, but it's not a convenience, and the surveyor is going to watch this really, really carefully. During the supervisory visit, if a competency is an issue, if there's something that is going on in the home that could impact patient safety, then the RN needs to come back, or the therapist needs to come back to the agency, let them know what the safety issue is, and then another competency on that home health aide needs to be completed. This is going to be something else that will be added to actually it's in the conditions of participation. I have not seen, now there may have been, but I have not seen myself citations on this. But since this has been identified in the final rule, I expect to see more citations in the competency in the future. But I guess I just want to point out that this virtual supervisory visit, be very, very careful of how you do that. Make sure you track it. Make sure that it's identified on your aide supervisory form, and you should be good. But surveyors are going to be really watching for this on an ongoing basis. This is kind of fun. Occupational therapists can now conduct initial assessments and complete the comprehensive assessment. However, this is for therapy cases only. So the not fun thing is that PT and speech still can't, PT and speech have to be in there to determine eligibility. OT can't determine eligibility. Why they did that, I don't know. It didn't make a lot of sense to me, but know that you just can't send an OT out to do a start of care assessment if they haven't already been determined to be eligible. So we still have, even though they can conduct the initial assessment and a complete comprehensive assessment, PT and OT has to determine the eligibility. Okay, so the mandatory COVID-19 requirements will still continue through 2024. Infection control will be a highlight again of surveys. So this has been, and one of the things that hospice agencies need to be concerned about is that the infection control requirements that nursing homes have had that impact them, because hospice, of course, goes in to do hospice visits into nursing homes. It won't affect home health care because we don't do home health in nursing homes, but you will still need to continue with the infection control requirements that your individual nursing homes have. So for hospice agencies, you may want to look at your contracts and make sure that they cover that, and that you are your staff will be compliant with those requirements in the nursing home. So let's talk about LUPA changes. For OT, since there isn't a history of OT and the time it's going to take for an OT to conduct an assessment, the LUPA rate they're going to use will be the same as they've used for PT and OT. So again, they're only allowing them to do the initial assessment, but they don't have enough data to come up with a LUPA rate. So that will show up next year. CMS is going to use the physical therapy rate for OTs. And so any add-on payment amounts will be that of the same as physical therapy. There's going to be a LUPA add-on to calculate add-on payments for occupational therapists. The add-on factor will only apply to the first OT visit and not subsequent visits in the episode. So again, your quality program updates. So dealing with your home health quality reporting, there are some changes that are going to be made to OASIS. And again, a lot of this is in OASIS-E. And so you're going to have to get ready. So they're going to be removing, I would encourage you, and if you don't have OASIS-E, let us know and we'll either send it to you directly or perhaps we'll have it on our posted already on our website. But one of the things they're going to do is remove drug education on medications provided to patient and caregiver, the patient caregiver measure. The other thing they're going to replace is acute care hospitalization during the first 60 days of home health. They're going to remove the emergency department use without hospitalization during the first 60 days of the home health measure, but they're going to replace it with removing measures with claims-based measure, home health within stay, potentially preventable hospitalization. This is where I said make sure that you train your staff on how to determine that and come up with numbers that make sense for each individual patient, and make sure that you're not using the same numbers for every single patient. Any public reporting required for percent of patients experiencing one or more major falls with an injury measure will be added. And so this is all going to be part of your star ratings. And that's one of the things you're going to want to make sure you get as close to 4.5 or 5 as you possibly can. That should be a significant goal for every single agency over this next year. There's going to be OASIS-E, as I mentioned, is going to start in 2023. There is a lot of information out there related to transfer of health information to post-acute care, using post-acute care measures to another entity. That's all going to be recorded in something called SPADES, a standardized patient assessment data element. They're going to be collecting data on two of these transfer of health measures, beginning with discharges and transfers after January 2023 on OASIS-E. You're going to have to really work hard with your staff members on this transfer information on OASIS-E, because this is going to be a significant part of the information they're going to use for your payment with value-based purchasing. They're going to begin collecting data on 6 categories of standardized patient assessment data on OASIS-E, with the start of care, the resumption of care, discharges, except for the hearing, vision, race, ethnicity, standardized patient assessment data elements, which will be collected at the start of care only, and that's going to begin in 2023. So pay attention. You're going to hear a lot about transfer of health information. The CMS is trying to find out where the best place for patients with a certain diagnosis, with certain home situations, certain environmental things going on. And so they're going to use this data, and it's going to weigh heavy on value-based purchasing. So there's a requirement to publicly report the percent of patients that are experiencing one or more major falls with injury. That is going to be another place that you're going to have to pay attention. So those fall prevention programs are going to take a whole new meaning as we go into the year of 2023. There's an application of percent of long-term care hospital patients with the admission and discharge functional assessment, and a care plan that addresses the function measures, beginning in April of 2022. So you'll expect to see some of those changes appear as we get ready and go into the value-based purchasing world. This is an exciting thing for me. I think it's a very cool thing that CMS did for us. We have for so many years struggled with IV therapy and that type of thing. This was introduced to us last year in the final rule, infusion therapy. So if you are a home care agency and you do a fair amount of infusion therapy, or if you would like to, and you have staff members who enjoy that, Medicare will actually pay us to provide IV therapy at home under Part B. They are going to, for 2022, the rates are going to be updated with a little bit of an increase using geographical factors with the wage adjustments that they see. But this is a way that you can actually add a revenue source to your agency under Part B. these patients don't necessarily have to be homebound because they're not a Part A patient, they're Part B patients. And it's something I believe that if you add, and you do have to become accredited as an IV therapy agency, and you do have a different Medicare number, a Part B Medicare number and that type of thing, but you can market to your hospitals. This would be a really interesting way to get additional referrals from hospitals. Many of the medications, not all medications, but many of the medications, including chemotherapy agents, are included in the payment for this. So it's an interesting thing for you to research, and I would encourage each of you to do that. Most of the accrediting bodies now have something in place where they can do the accreditation for the IV therapy. These are the references we've used for this presentation. And I would encourage you to download some of these and take a look. Some of them are somewhat boring to read, but there are some of them that have a lot of good tips for you and will help you work through this. These are some of the support and resources we have for you in going into 2022 and 2023. These are going to be two really, really big years for us, and it's going to bring a number of changes to our industry. And I would encourage you to get ready, review your policies and your procedures, take advantage of all of the help that we give you on recommendations and resources and training. So with that, I'm going to end this session, and thank you so much for listening, and we will see you next time.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.